In March 2026, a highly localized bacterial outbreak began in Canterbury, England, with early cases tracing back to a local nightclub called Club Chemistry. Within days, the situation escalated. Health authorities recorded 27 confirmed cases and 2 fatalities, leading to scenes reminiscent of a pandemic as university students queued for emergency antibiotics. The culprit was meningitis B. It is a highly aggressive bacterial infection that targets the meninges, the protective membranes surrounding the brain and spinal cord. The onset is terrifyingly fast. Early symptoms like severe headaches and vomiting easily mimic a typical hangover, but within hours the infection can deteriorate into sepsis, a life-threatening condition where the body's immune system overreacts and begins damaging its own tissues. The UK actually possesses a highly effective vaccine for meningitis B. Yet dozens of young adults in Kent found themselves fighting for their lives without immunological protection. Meningitis B does not spread through the air across a room like COVID-19 or measles. The bacteria requires prolonged, close proximity contact with respiratory secretions to jump from one host to another. That means it relies on specific social behaviors to find new hosts. Transmission happens most efficiently in densely packed halls of residence, through intimate kissing or sharing drinks and vapes. The daily routine of a typical university campus provides exactly the kind of macroscopic social density required to ignite this specific microscopic threat. In 2015, the UK government launched a national vaccination program to combat meningitis B, utilizing a vaccine known as Bexsero. This chart outlines the 2015 rollout. The vaccine was provided exclusively to babies, a deliberate public health decision made because infants historically suffer the highest fatality rate from the disease. But look at the math for today's teenagers. Current 18 to 20-year-old university students were born years before this rollout began, meaning they completely missed the protection window. Many young people assume they are protected because they receive a routine meningitis shot in secondary school. That adolescent vaccine, called MenACWY, protects against strains A, C, W, and Y. It leaves a complete biological void for strain B. Even if today's students had somehow received the Men-B shot as infants, they would still be vulnerable. The immunity provided by the Men-B vaccine is relatively short-lived and degrades well before a child reaches young adulthood. Due to this exact combination of rollout timing, public policy, and vaccine biology, an entire generation of young adults is currently navigating the world in a complete immunological blind spot. Once the cluster in Kent was identified, the UK Health Security Agency, the government body responsible for protecting the public from infectious diseases, abandoned long-term prevention strategies and pivoted directly to emergency containment. Their immediate response was the rapid deployment of prophylactic antibiotics. They administered ciprofloxacin to over 2,500 close contacts of the infected students to break the chain of transmission. The secondary tactical response was a targeted emergency vaccination program, strictly isolated to the 5,000 students living in high-risk campus halls of residence. The medical logic behind this two-pronged approach comes down to speed. Antibiotics work almost instantly to kill the bacteria upon exposure, while vaccine immunity takes about a month to fully build up in the bloodstream. Because proactive national immunity does not exist for this age group, public health officials are forced to fight the disease through highly localized, reactive firefighting. News of the Kent outbreak triggered a wave of anxiety among parents across the entire country, far beyond the initial infection zone. This led to a massive rush on private pharmacies. Families willingly paid a steep £200 out-of-pocket cost per shot, creating severe supply shortages at major retailers. This panic exposes a two-tier public health reality. For anyone outside the targeted containment zone in Kent, protection from a lethal bacterial strain is dictated entirely by a family's ability to pay for it. The outbreak has forced a political response. UK Health Secretary Wes Streeting has formally requested a re-evaluation of adolescent vaccine eligibility. That decision rests with the Joint Committee on Vaccination and Immunization, or JCVI, a group of independent experts who act as the gatekeepers for the National Health Service schedule. The JCVI operates on the principles of epidemiological economics. They dictate public health policy based on strict population-level cost-benefit analyses, weighing the price of an intervention against the statistical number of lives it will save. The committee must decide if the immense financial cost of routinely vaccinating millions of teenagers is justified to prevent rare, localized outbreaks. Medical authorities warn that recognizing the disease early is critical. Watch for a sudden high fever, a stiff neck, and a distinctive rash that does not fade when you press a glass against it. While the government debates the economics of the immunity gap, immediate symptom recognition and rapid medical intervention remain the only true safeguards against the clock.